Welcome to the Making Connections webinar series. This webinar is presented by the Fall Prevention Community of Practice with technology support from the Seniors Health Knowledge Network. My name is Lindsay Toth, and I am a project coordinator at the Ontario Neurotrauma Foundation, which sponsors the COP. Marguerite Thomas also joins us on the line today. She is the coordinator of the Fall Prevention Community of Practice and will be assisting with the webinar technology. Before we begin, I'm going to give you a quick rundown on the Level 3 web meeting system. This webinar technology consists of two parts. The audio is provided through a telephone conference line. The visuals are provided through a web platform. The phone number for the conference line and the link for the web platform were sent to you by email after you registered for the webinar with Level 3. If you have questions about the technology at any time during this presentation, please type them into the chat box located on the left-hand side of your screen. Alternatively, you can send me an email to lindsay@ons.org. I will work with you to resolve technical issues as soon as possible. This webinar will contain an opportunity for discussion during a question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, I will read those questions aloud to the presenter. If you would prefer to ask your question over the phone, when prompted, you may unmute your line by dialing *7. When you're finished, please dial *6 to re-mute your line. This webinar is being recorded. The recording and the slide deck will be distributed by email after the webinar. I would now like to introduce our speaker, Sally Boyle. Sally is the program lead for the Southwest Self-Management Program at the Southwest CCAC. Sally, you may now unmute your line by dialing *7.
Thanks, Lindsay.
All right, take it away whenever you're ready.
Okay. Well, thanks everyone for joining us on the line, and thank you, Marguerite, for inviting me to speak about this topic. Just to give people a brief overview of our program, we're the Southwest Self-Management Program. We're located in the Southwest LHIN in Ontario. I'm not sure where people are calling in from or connecting. So we service the people in our LHIN, and we run workshops for people living with chronic conditions and their caregivers, as well as do education for healthcare providers. So health literacy was a program that we developed almost 4 years ago now, and we run free workshops out in the community for healthcare providers. So this is basically a snapshot of the actual workshop. The workshop's usually about a half a day long. So I apologize, it is a little bit more didactic this way. During the workshop, we usually have activities. So on the slide, you should see a definition of health literacy, and there's many definitions out there. This is a Canadian one. And basically, it's a person's ability to access, understand, evaluate, and communicate information in a way to promote their health. So no matter where they are in the health continuum, whether younger, older, it's a way that they need to be able to understand and be able to use that information. And years ago, the definition would stop there. It was about the patient, the client, the resident, whatever it is, whatever term that you use. And I apologize, you may hear me say patient because here at the CCAC, that's what they use, but I know in other organizations they use different terms. But basically, it's the people that we serve. So as I mentioned, the definition usually stopped here, and we put all the responsibility on the patient. But with research, we know that now health literacy also includes our responsibility as healthcare providers, as professionals, as institutions. We have a responsibility to the people that we serve, and making sure that we're clear, we're concise, and that we check for understanding. So the responsibility isn't just the patient or the person, it's our responsibility as well. And really a lot of it lies with us. A lot of times I think as healthcare providers and institutions, we think we do a good job of communicating, and sometimes we do. But the research shows, and just even in anecdotal evidence through our program, that patients think otherwise. So health literacy and self-management, really self-management is about a person's ability to manage, on their own, when they're on their own. And so, to the optimal level that they can. And so in order for people to take part in their health, to take part in decisions, patients, clients, their caregivers, their loved ones need to be able to access information. So they need to be able to understand where to get the information. They need to be able to understand the information. So when information is shared with them, whether it's verbally, whether it's in print, on a website, they need to be able to understand it in a way that they can apply it. They need to be able to evaluate it. So if people are given options, for instance, for care or for treatment, is option A and there's option B. They need to be able to definitely understand both options. What are the risks? What are the barriers? What are the benefits? So that they can make an informed decision. They need to be able to communicate with us and not feel like they're imposing or not feel like we're making them feel inadequate. They need to be comfortable to be able to ask questions and to say, you know what, I don't understand what you're trying to say to me or explain to me or this pamphlet you've given me. They also need to be able to apply the information. So, they need to be able to go home, or maybe you've seen them in their home, they need to be able to apply it to their everyday life as they, go about their lives. We often talk with care coordinators here that see people in their home and everything seems fine, and then the minute they leave, the patient was too embarrassed to say that they didn't understand something, and now what? So really, health literacy bridges knowledge with behavior, and we need these skills no matter in sickness or in health. We need those skills. One study that the American Medical predictor of health status than age, income, employment status, education level, race, or ethnic group. So, that's a lot of weight behind the importance of health literacy skills. And you'll hear me possibly talk about different studies, and I will say to you that a lot of them are American, and the reason for that is the States is probably about 15 years ahead of us on this topic. They have Plain Language Act in place. They have a variety of tools and legislation in place, and we're getting there. But a lot of the research has been done in the States, in the UK, and Australia. So this slide I just put up, we actually use this as part of our program when we're out there communicating not only with healthcare providers, but actually even with people, patients that we serve. And these are the stats. So in the next 2 decades, the number of people in Ontario that are going to be 65 and older will double. The number of people 100 years old and over will triple. And the number of people 85 and older will quadruple. And I think that's very important, especially to this group that, you deal with a lot with, of course, with falls prevention, of course, and probably many of the people that you work with are seniors. And 70% of Ontario seniors will have 2 or more chronic conditions. So a lot of chronic conditions, sometimes people think, well, why would that lead to falls? But if you have low blood pressure when you stand up, or changes in medication, dehydration, different things can lend, to the risk of having a fall. And so it's important that people keep that in mind, not only healthcare providers, but patients as well. One thing that I talked about around self-management is that we need to be able to empower people to feel confident that they have the skills, the knowledge, and the know-to to do what they need to do, and to look after themselves the best that they can. But there is a disconnect. Oftentimes I've heard many healthcare providers say that, so-and-so's come in again, they're a frequent flyer, or they're always in our office, or we're always having to visit them at home, or whatever it may be. But in reality, people only spend about 12 and a half hours a year with a healthcare provider. Now, this is on average. This was a large study done in the UK, and it's been replicated, and basically the same results were found. That on average, somebody with a chronic condition spends 12 and a half hours a year with a healthcare provider. And that healthcare provider doesn't have to be a physician. It could be a dietitian. It could be a nurse. It could be a chiropractor. But the other 364 and a half days a year, they're managing on their own. So how can we better equip them? And in order to do that, when we share information, we need to be sure that we're sharing it in a way that people understand, people feel comfortable, and people can apply it and to check in with them to make sure that they understand. So this report was actually done in 2008 in Canada. It's one of the last reports done so far, but the evidence shows that it's about the same. So in Canada, what they found in this report, so people 16 years and older, they found that 60% of adult Canadians struggle with understanding health information. And when you look at more specific groups like seniors, 88% of them struggle with health information. And again, it doesn't mean they can't read and write, and yes, there may be those issues, but for a lot of people, they can read and write, and many have university degrees. It's the way that the information is shared, it's the jargon that we use, and we don't follow through with them. So it's important to note that the majority of the public may struggle with understanding health information. So these are the most vulnerable groups. So older adults over the age of 65, low-income, unemployed individuals, our immigrant population, a limited proficiency in English or French. So depending on where they live in our country and if they've moved from a different country, or for instance, I only speak English and another language but not French, and if I was to move to Quebec, I would probably struggle with understanding information. A low education level. It is a factor, but I will stress to you that this is not the most important factor. A lot of times people think that, the patient didn't finish high school, or the patient has a university law degree, they should understand. Not necessarily. We speak in a different way, we write in a different way in healthcare, and we take for granted that the nurse next to us understands, and sometimes they themselves may not. But we take for granted that our patients should understand this. And low health literacy disproportionately affects more people with chronic disease than any other disease state. So when you think about things that are more acute, like for instance, someone having gallbladder issues, and they go in, they see a family doctor, maybe referred to a surgeon, and maybe they need surgery. If all goes well, they go in for the surgery, they have the gallbladder removed, they heal, they do well, and they don't have to worry about it the rest of their lives, basically. But with a chronic disease like diabetes, osteoporosis, depression, those diseases are there for the rest of their lives. And so they need to manage, the symptoms that come up, the complications, the changes in their lifestyle, the changes to their routine. And so it's great that there's always new technology, new medication, but that means also new learning. And so especially for our senior population, it can be a barrier. And we need to keep in mind also with the vulnerable population that sometimes we don't think about is the caregivers are a group that is often overlooked. And oftentimes the caregiver, whether it's a spouse, a son, a daughter, a family friend, whoever often has the charge of helping that person manage their health, we need to check in with them as well, because sometimes they're the ones that are taking in the information and sharing it with the individual. So these are some outcomes related to people that struggle with low health literacy. Reduced health-related knowledge, so maybe about their condition, maybe they're not sure what diabetes is, maybe they're not sure on how to treat their depression, that sort of thing. Poor self-management skills, meaning that maybe we've shared information with them, or even something clinically that they have to do at home, like test their blood sugar, or do certain exercises, to promote their strength. But they're not sure about how to do that once they go home. They tend to use preventative care services less. So things like going in for, women at a certain age going in for a mammogram, especially with a family history, or colonoscopy for anyone, or even a flu shot. It's not that they don't want to go. It's because they don't understand the benefits, the barriers, and also the pros and what could help them. Medication errors is a big one, and I hate the word that healthcare providers often use, non-compliant and non-adherent. Really, a lot of times, especially around medication errors, the biggest issue is that people just don't understand how to take their medication, or they're unsure, or the side effects scare them. In 2013, our actual Canadian federal government did a study that found that 1 in 9 emergency room visits were due to drug adverse events, and 68% of those visits could have been prevented. And it was usually because somebody took their medication wrong, not enough, too much, wrong time of day. So just to keep that in mind. They tend to use emergency room services more, and there's increased hospitalization. Sometimes by the time they figure out that something's wrong, or they don't catch symptoms or complications early, they end up in hospital. And the other piece of it is learning how to navigate the healthcare system. Even us as healthcare providers, we probably struggle with knowing who to call for this or that, and we're constantly researching. Think about our patients that don't have that experience of working in the healthcare system and having to navigate, where to get help. They tend to have a higher mortality rate and higher healthcare costs as well. So our next slide really just talks about what health literacy impacts. It impacts people's access to care around navigation of the healthcare system. It impacts their safety. It impacts quality of care, their experience with the healthcare system, and often in the end, their health outcomes. So there are many factors that influence this, and these are the three main ones. Providers. As healthcare providers, as institutions that deliver healthcare, often our communication skills aren't the greatest. Sometimes they are, and sometimes they're not. And people tell us that we speak too quickly, we speak in a language that they can't understand, or write in a language that they can't understand. Most patient education materials are still in print or at least on the web. And again, patients tell us they're so complex and then written in a way that they're not sure of what to do. And places, think about where you share information with the individuals that you work with. Is it in a busy emergency room department, or is it in their home? But maybe there's 5 or 6 family members all around and bombarding you with questions, and you're trying to share information with that individual. Think about that. Even signage. Think about signage. If you have people come in, I'm not sure what everyone's role is that's on the phone, but think about signage. If you have people coming in to see you, maybe in a hospital or in a clinic, is the signage clear? Are the appointment cards clear? Do they know of when to come back? I'll give you an example that when I worked years ago in diabetes education, I had a patient that we worked in a small community hospital. I live in a very small community, and we had a patient that was referred to a larger urban center for an appointment with a nephrologist. He was having some kidney issues. And so the gentleman and his wife went to this large urban hospital, and he said he went, he parked, he walked and walked and walked, asked questions on where he was going. Nobody seemed to know where he needed to go. He got frustrated and came home. And the next morning, the doctor's office nurse basically called to ream him out, saying, why didn't you go? We set up this appointment. It takes months to get in, And he said to me, and he said to the nurse, he said, I went. I was looking for something that said kidney care, and the signage at this hospital actually said nephrology. So I get that nephrology is around, a kidney physician, someone that deals with kidney problems. But when you think about signage in a hospital or in a medical clinic, it should be geared to the patients. They're the ones that are usually looking for where they need to go. And to have nephrology doesn't mean anything to them. Now, we didn't do our due diligence of explaining to them, and I never even thought of, to say, the sign that you may see is nephrology. It never even crossed my mind, but I will tell you from there on in, it sure did. And so any time that I've worked with patients, and they were going to different appointments or whatever it may be, I've definitely taken the time to think about that as a factor. So there are individual skills and system demands. Now this slide, I will tell you, is actually American-based. This was research done in the States, although it's been shared with me that it's very similar here in Canada. So this is just basic literacy skills, not health in general, just basic literacy skills. The average literacy skills of a working adult is grade 7 or 8, or lower in those most vulnerable populations. Most health information is written at a reading level of grade 10 or higher. Research or informed consent, think of consent forms like for services, think of consent forms for surgery, whatever it may be, are often written at a college level. In verbal communication, patients tell us that we speak way too quickly in a foreign language, or in words or sentences that they cannot understand. So when you think about, the brochures we're handing out, or even verbally how we're explaining things, we really need to take into consideration that, yes, somebody could have a university degree, somebody could have finished high school, and I'm not trying to downplay that they're not smart individuals, they are. But we could have people that understand and others that don't. And so it's important to keep that in mind. So what can we do to foster better conditions for self-management, for people to be more successful in their health? Well, we need to be aware of a few things. So there's red flags, and this isn't the be-all and end-all to the list, but these are just some things to keep in mind. So if you have people that maybe need to fill out registration forms for you or other forms, maybe that you need some kind of history on them, look for, are they being completed correctly or incompletely? Maybe some people will write their name and don't write anything else, or maybe they pass it off to their loved one that's with them and say, well, can you fill it out for them? That may be an indicator that they're struggling with some literacy issues. Maybe not necessarily health, but literacy issues. I've had patients where they've actually pulled out, their license or, a health card to write some of that information down because they're copying, the information. Written materials, again, if they're handed to a relative or a person accompanying them, or maybe they may say, I'll take this home to read, or I can't read it now, I forgot my glasses. And for those of you that wear glasses, I get it. You can forget your glasses, leave them somewhere. But if this is a continual thing, maybe they're almost the other way. They seem aloof or withdrawn when you're trying to explain things. And, we all have seen that glazed eye look or deer in the headlights look. Be very aware for nonverbals. And sometimes they, share with us that they're struggling, not verbally, but, they miss appointments because maybe they didn't understand that, the appointment card said you have to go do blood work first, then you got to come down to the elevator on the first floor, and then you have to come down to room, 186, whatever it may be, and they get frustrated. They could show through errors in medication or self-care instructions. Maybe, provided them with a list of exercises and diagrams, how to do it at home, but they're still struggling with it. Just keep that in mind. I'll be honest, I had a big red flag for me was years ago in working with a patient who had been seeing us for quite a while. And, we saw them regularly, sort of as a follow-up every 3 months or so. And one day, my colleague was sick, and we had to rebook a lot of our patients because they normally saw me and the dietitian. And so we called this individual and, told her, unfortunately, we can't see you today, but, we rebooked you. And our secretary, assistant, rebooked her. Unfortunately, the day that she rebooked her, this patient didn't show up. And I kind of got concerned because she always showed up for appointments. She was elderly. She lived alone. She had some issues with depression, and I was afraid that maybe something had happened at home. So we called her up, and she answered the phone. And I said, so-and-so, you were supposed to be here for an appointment. Is there anything wrong? Is there anything you need? And she said, oh, I'm so sorry I missed the appointment. And so we rebooked it. But she was very specific this time on wanting a certain day of the week and a certain time. And so, we figured it was something to do with how to get to the clinic. And so maybe she had a ride on certain days, whatever it may be. Only when she came back, she actually broke down when we talked a little bit more. We didn't really pry. We just, were talking about, how we were concerned that she missed the appointment and, but we were here today and moving forward. She actually broke down, and this is after probably a year and a half of seeing her, that she broke down to tell us that because we switched her appointment, we basically switched her whole schedule. She was pretty much illiterate, had been like this all her life. She was already in her 70s. And the way she knew how to come to our clinic, and I think she based many of her appointments on this, was it was based on a certain day of the week because a certain show was on at a certain time on TV. And she knew when that show ended, she had half an hour to get to our clinic. And so when we switched the date and the time, that, messed up her whole schedule. So I stress to you, this is an extreme case, but I always share it with any tiny workshop that I do, that people are very good at coping. People are very good at covering up. And this is a literacy issue, maybe not necessarily health, but the two can be tied together. So it is a silent epidemic. Healthcare professionals are very poor at identifying patients that may struggle with health literacy. Education is not the be-all and end-all marker. And health literacy is very context-specific. So it's more of a state, not a trait. And what I mean by that is that sometimes, even as a healthcare professional, I could struggle with health information because, for instance, I know a lot about diabetes because I worked in that field, and put me on a cardiac care floor or something that I'm completely not familiar with, I will struggle with understanding that information, let alone a patient. So think about patients who on a normal day-to-day do very well, and then we throw them into a crisis because now they're in pain or now they've fallen and broken something. And the stress level is a lot higher, and stress affects the way we learn as well. So people are very good at using effective coping strategies, and we even see that in early Alzheimer's patients, right? They understand, they know that they're forgetting things or misplacing things, but they're very good at covering up. So what I want to stress to you is that you can't tell by looking. That somebody that you work with, as a patient, as a person that you serve, that you'll be able to tell by just the way they look. If they walk in a three-piece suit, they're going to get health information. They know what to do, not necessarily. So in thinking about that, keeping that in mind, is that we need to make it safe, we need to make it simple, we need to make it accessible for anyone that we serve. And so in the U.S., they actually developed a Universal Precautions Health Literacy Toolkit. And I believe in an email that will be sent after this webinar, Mary Beth has nicely put together some resources that include this, and you'll be able to access it and see some of the information in there. But basically what it is that we need to expect at every encounter there's a risk for miscommunication. There's a risk that people may not understand. They may be in a crisis, they may be in pain, they may have lack of sleep, and all those things can affect how well they can take in information. So we need to make it a shame-free environment. We need to treat everyone equally, anticipate maybe barriers that may come up, communicate clearly with everyone, and confirm understanding. And sometimes we do a not too bad job of communicating, but we don't check in. We don't check for understanding. And so also proactively work to minimize barriers. So if we know that people are having issues with our signage, or we know they're having issues with our brochure, what can we do to proactively work with them to change that? So around creating a shame-free environment, we need to be aware of the setting, right? Where are we sharing health information? Is it conducive to learning? Is it quiet space where people can focus? Is it giving them enough time, not rushing them? Making sure our instructions are clear and concise, and whether that's appointments, whether that's exercises we're sharing with them, whether it's around medication, whatever it may be. We need to encourage them to have a support person with them if they can. Two heads are always better than one. And so we always encourage people with our workshops to bring a loved one with them, bring a friend, that sort of thing. We need to encourage questions, and we're going to talk about that in a few minutes, but we need to make sure that people feel comfortable and safe to ask questions of us, if they don't understand. And we need to remember that we have 2 ears and 1 mouth for a reason. It's to listen and to speak less. And so giving people time to respond, if we ask a question, don't bombard them with 20 questions in 20 minutes, right? And giving them time. Also, being aware that one of the most respectful things that you can do is ask for permission. And what I mean by that is that when you're working with people, before you bombard them with information, whether print, verbal, whatever way, that you stop and check in with them and, just say, would it be okay if I shared some things with you? And see what they say. Maybe they're not ready to listen. Maybe they're not at that point yet that they can. And if they say no, then respect that. But it's the most easiest way to build a relationship and also the respect of the person. Ask for permission, or even ask them, what have they already tried? Because sometimes people are frustrated. They've tried all these different things and they're still struggling with their balance, and they've bought all these assistive devices and they're still struggling and they're still having these falls. So, keep that in mind. The studies actually show that people that end up in our emerge, for whatever reason, have actually tried 7 different things before they've actually come to emerge. So the last thing we want to do is disrespect them, that, they come in and see us, whether emerge or, coming in to see us. And, we go through all these questions. Well, did you try this? Did you try that? Did you try that? And, that can be frustrating for them. So ask them, what have they tried, so that you're not repeating things and frustrating them. Be aware of privacy. People that are struggling with information will maybe feel ashamed, oftentimes feel like they don't want people to know that they don't understand, especially people with a higher education level. They will feel almost like they're obligated that they should know this stuff. And, I always give the example that I'm a nurse, and I've gone to see my family physician who knows I'm a nurse. And I took my daughter in once, who is very athletic, and I took her in because she was having some knee issues, some knee pain, and it was keeping her from doing activities and even, everyday things. And so I took her in, and he examined her, and then he turned to me and said, "Oh, it's just Osgood-Schlatter's disease." I can't even say it, to be honest. And she looked at me, I looked at him, nobody said anything, and he made it sound like it was no big deal. And what I should have done is said, "What is that?" I didn't. We got in the car and we Googled it. And I'm a healthcare provider, but I felt ashamed because here I am a nurse and he's using this word. All it meant growing pain. That's what it meant, and that's all he needed to say. But in the meantime, on the car ride home, my daughter's, worried that she has some kind of major disease. So keep in mind that we can't assume that even if people are healthcare providers, that they're going to understand everything. And watch your body language and your tone of voice. The way you deliver information the body language is just as important because that can, ruin a relationship that way. So we talk about clear language, and you might hear clear language, you might hear the terms plain language. These are all the same terms, and basically it's about how do we communicate with people in a simple way. And I just throw this cartoon up because many times in organizations this is what we do. We develop things over and over, and there's something to explain that pamphlet in this. And really in the end, nobody understands the information. So clear language, fact or fiction, these many times when I do workshops, these things come up. And so they say, well, some people will challenge me and say, well, if we speak plainly, it limits the information that can be provided. And really it doesn't. It just makes more work for us, that we have to think of different ways of how to deliver that information. Some people feel that it will insult adults, that it will insult patients. And truthfully, in any of the patient workshops we've done, nobody ever says that. Nobody has said to me, well, why are you speaking that way? Or, why don't you just give me the medical term for it? It's not that we don't want people to learn, and it's great to give them the medical term, but you need to explain what that medical term is, just to be sure that everybody's on the same page. The other thing I've heard is that it can create legal risk, and actually the legal risk is if you're explaining something or getting somebody to sign, a consent, and they don't understand, that's actually the legal risk. So keep that in mind. And some people think that, well, clear language or plain language is just common sense. We do it all the time. Not necessarily. One of the activities I normally do in our half-day workshop is I give people a list of words, and I get them to try and say it in a way, whether it's a word or a phrase that people, could relate to. And it's amazing how hard it is to come up with something that's more simple than what we're used to, the words we're used to saying, like ambulate or heart, or not heart, sorry, cardiovascular, those sort of things. So make sure that when you're communicating with patients, whether print, whether verbally, that you simplify and add those personal factors. As a nurse, I know, and many of you as healthcare providers probably went to school and we were taught to be very scientific, speak in third person, or when you're writing, do that in third person. But really what patients want to hear is I, we, us, and keep that in mind. Avoid jargon and acronyms. So jargon meaning, we'll go through a few words in the next slide, but meaning words that maybe we only use internally. Maybe it's words that we don't even think is jargon because we use them all the time for the last 20 years, but not realizing that for patients this actually is jargon. And acronyms. Acronyms is a big deal, especially in healthcare. And so we need to make sure that if we're using an acronym that we want people to learn, that we make sure that we explain what that acronym is. And it doesn't mean just spelling it out. So for instance, AIDS, most people recognize AIDS, what AIDS is, instead of spelling out acquired immunodeficiency syndrome, but explaining what the disease actually is. So it might, simplifying things doesn't mean just one word or one sentence. It actually might mean a few sentences in explaining things. Internally, when we've done workshops, even with our internal staff, because we're situated at the Southwest CCAC, we don't service just clients of the CCAC or healthcare providers here. We're just housed here. But we've done some internal work with staff, and it's interesting. We've had staff from our care coordinators who are all clinically educated, individuals. We've had people from our business office. We've had people from IT. And I've given them a list of acronyms. And it's amazing. As in an internal organization, we all think, an acronym means something different. So I'll give you an example. One was ADP. And for the care coordinators, there was some that said it was Assistive Devices Program. Other care coordinators said it was Adult Day Program. And I can't remember off the top of my head, but the IT people had their own, whatever it stood for in the IT world. So, think about that even with your own colleagues and professionals that you work with, that, it isn't just with our patients. We need to be clear with each other so we all know we're on the same page. So keep that in mind. Get away from fillers. And what I mean by fillers is sometimes when we speak or sometimes when we write, we think we need to sound really, really professional, and so we add these beautiful adjectives or, difficult words, but it's not doing justice to our patients. And add real-world examples. So maybe you're discussing how the blood flows through the body with the patient. If he's a plumber and you know that, try and relate it to something like that, something that they can relate to. Sometimes when I worked in diabetes education, we'd talk about how much protein they could have on their plate, and, we'd refer them to a deck of cards, about the size and the thickness of a deck of cards. Now, men weren't always happy with that, but, that was what we were relating it to, so they had something to think about. So this next slide is just, reminding you, watch your words and your numbers. So words can have multiple meanings. Diet. Diet is a word that sometimes we as healthcare providers, all we really want to know is what do they eat on a day-to-day basis, what do they eat for lunch. But when we use the word diet with patients, sometimes we get this look like, oh my goodness, am I supposed to be losing weight, or should I have been on a special diet, meal or something like that. Stool. Many of you will laugh, but stool is actually a medical term that we use in healthcare. The average Joe who, maybe has had maybe they haven't seen a physician, maybe they haven't been in a hospital, stool is something they sit on. And actually this example came up in actually one of our patient education sessions that we did, where a lady gave us an example that, she didn't know what the doctor was talking about when he wanted a stool sample. And when she actually felt empowered enough to ask what it was. And she says, he fumbled on his words, but he basically got out what he actually meant in simpler terms. Dressing. Dressing could be somebody getting dressed. It could be dressing as a nurse in a home care environment. It could be a wound, that has a bandage on it. It could be salad dressing. So, keep in mind that depending on the person and what they understand, what they think it might apply to in their lives. Even the word gait. Gait is something that, often in physio or OT use. And gait means one thing, but for a lot of people, gait means something like on a fence that you open up, right? So keep that in mind. It doesn't mean that they can't understand what gait is, but you need to explain to them that, gait is this, your ability, your balance, those sort of things to walk. Watch the acronyms like I mentioned, and it's not that we don't want people to know what acronyms are, but for instance, in this example here on the slide, HDL is when we would explain it to patients, we'd say to them, it actually stands for hypodensity lipoprotein, which means nothing to them and probably to me either. But to patients, we'd explain to them, it's your good cholesterol. And so these are the foods that can get your good cholesterol up in order to fight the bad cholesterol. So just keep in mind. And if you are giving them measurements, think about giving them the healthy number first. So if there's a normal range, and I'm not sure in your roles whether it be maybe blood pressure, in my role it was, blood pressure, it was blood sugar levels. It could be maybe you're talking about bone density and what the normal is and where theirs is at. Just keep those in mind, but always give them what the normal range or the range that, we hope to get them to, or maybe they're there already, but give them something to compare to. Because by telling somebody that their blood pressure, is, 190 over 100 may not mean anything to them. Idioms don't always work, so be very careful, especially with different ethnic or cultural groups. I use this example here, are you feeling blue? Because I have used that, and I've literally had a patient look down at themselves and look at their arms and hands thinking, is she asking me if I'm blue? So what I actually meant was, were they feeling sad? Do they cry a lot? Do things upset them easily? So these are Western cultural idioms that we use, and we need to be careful of that. Another example we had is we worked with a partner at a community health center who deals a lot with immigrant population, and they actually shared this example with us. And their community worker went to the CNIB, which is another acronym, right? So the Canadian National Institute for the Blind, and they took a client there. She was a lady that had immigrated here from an African nation, and she was basically, almost blind. And they took her there to see if there was any strategies, any tools that could maybe help her. And one of the questions, the assessment questions that CNIB had was, are you legally blind? And the poor woman, when she explained back to the worker who was interpreter, she was so fearful. She says, is it illegal to be blind in Canada? And so we need to really keep in mind that sometimes things don't translate, or they translate literally, especially with different cultural backgrounds. And depending on where you work, and if you have a larger immigrant population or a different culture, be very aware of that. And always explain the difference between is and may. There is a difference between something will cause something or something may cause something. And make sure you explain that. So if you're, especially in written work, but this goes with, when you're speaking to people too, but especially if you're writing something for a patient. So maybe you're developing a brochure, or maybe it's just written instructions that you're writing out. Keep it, we're going back to English class, one idea per sentence. Words, what they actually say with health literacy is to make it 2 syllables or less, which is very difficult in healthcare. But do your best, and if there are words that you need people to understand, then that's fine, but explain what they mean. Average sentence length should be no more than 15 to 20 words. And always use a positive tone. So avoid, you must do this, you should do this when you go home. Make it more open. Make it more positive, in order to, reduce your risk of falls, the benefits of doing this exercise would be, or whatever it may sound like in your area that you work. As far as writing, developing something written, no more than 2 fonts, one for headings, one for text. A 12-point font minimum is the minimum. 14 for seniors. Some seniors prefer a little bit bigger. If you get too much bigger, it can actually make it more difficult to read. But then again, if you have people that are legally blind or have some issues, that is different. Make sure that you use upper and lowercase letters. Stay away from all caps when you're writing or typing. We all hear that, all caps means you're shouting at people, but it isn't just that. The way our brain works is that even from a very young age, even as we're learning, phonics and learning how to read, is we also, our brain actually learns the shape of words. And so it needs to see that at the beginning of a sentence is a capital T, and the shape of the word starts that way instead of a small t. Use bullet points. Stay away from a lot of text that's a lot of paragraphs in writing. Use bullet points to be concise and straight to the point. And always use left justification. And what I mean by that is when you're writing a document, make sure the left side of your page is all aligned. The right side can be ragged, meaning it doesn't matter where the sentence ends. But make sure the left side is all aligned. What happens is if any of you have ever noticed, and sometimes in, let's say, scientific journals or your professional journals, when they do articles, they actually align both the right and the left. And I've never, until I did research on this, I never really realized it. But it actually makes it more difficult to read because there's actually extra spaces between words. And so for people that are struggling with health information, and if they struggle with literacy issues in general, it makes reading more difficult. So make sure it's left justified. The right, it doesn't matter. It's ragged, meaning it can end wherever. But never hyphenate words either at the end of sentences. If it doesn't fit on that sentence or in that bullet, move it to the next line. As far as color, if you're developing document, contrast is always best. Non-glossy paper. The best thing is dark print on a light background. Black print on a white background or a very light background. Stay away from neon color backgrounds. I know sometimes people with flyers and that think about that, that's going to catch people's attention, but it actually makes it more difficult to read. Avoid reverse text, which is when you get like a white writing on a dark background. That can be more difficult too. A little bit of it is okay, but you don't want the whole flyer, brochure, or pamphlet to be that way. Stay away from watermarks or shattering. So what I mean by that is sometimes some organizations have their emblem or their logo, and it's kind of just faintly in the background on a piece of paper and writings over it. Stay away from that. It's okay to use your, add your logo or whatever, but maybe at the top of the page or at the bottom, not to disturb with the reading, the text that's actually there. Stay away from text that's, in these colors, red, purple, pink, yellow, anything that, we're trying to make it, we think we're making it aesthetically pleasing, but it actually makes it more difficult to read. You're better off sticking with black or a dark blue. And older adults actually don't see blue or green very well, so keep that in mind as well. As we age, those things change in our retina. It's important to keep in mind that when you're developing materials that maybe you use visuals as well, and I would encourage you to do so. The average recall without pictures or visuals is 15%, but if you add visuals, it's actually 85%. And so keep that in mind. Visuals can simplify things. It can make it memorable for people. Oh yeah, I remember that pamphlet. It had that gentleman on the front, or that exercise, whatever it may be. It reduces reading, so people that maybe are struggling with literacy issues, they don't feel they're getting a pamphlet that's all text, and that will be overwhelming for them. So if there's some pictures, and the pictures should relate to and appeal to the audience, whether it's culturally, whether it's by age, whatever environment, but it should appeal to them. You shouldn't have a child on the front of, something for seniors just because it, it prettied up the space and it covered some space for you. And some people are visual learners, and so sometimes if we're giving visuals, then that's great, and maybe put captions, especially if it's something, an activity you need them to do or want them to do, have the diagram of how to do it, but then actually have the writing below it or next to it as well. So use a variety of resources when you're working with people. Not everybody learns the same way. Not everybody, people use different ways altogether. And so use a combination. Use print, use verbal. You can use videos. You can use audio, especially for people that are having visual problems. When we run our workshops out in the community, we run the Stanford program, and everyone gets a book. It's for free. It's a resource book. But for individuals that have, struggle with vision, maybe you've had a stroke and have a difficulty reading, we also have an audio book that they actually can take home and keep. Use pictures, use posters, use models. Dietitians are great, food models. I always thought that was the best thing in diabetes education, because you could actually show people, what an ounce of this is, or, a steak should be, or whatever it is. And mark them up. The studies actually show that if you hand somebody a brochure or a pamphlet or whatever it is, put their name at the top and highlight areas or underline areas that you really want them to focus on. Sometimes I've had the experience, and many colleagues have told me the same thing, that sometimes we use pamphlets or brochures that aren't developed by us, but it's maybe standard in our organization that they want us to use these things. And so what I would say to you is if you're using a document that you feel maybe has got too much text, but the organization wants you to give these to patients, so you're trying to satisfy the patient side but also the organization side. What I say to you is read through the document beforehand, or be prepared, and underline or highlight areas that you really want the patient to focus on. So, for instance, in diabetes education, the Canadian Diabetes Association has some great information, some great pamphlets that we would use, but sometimes I find them overwhelming myself, and so what I do is I'd give the patient the information and say to them, there's a lot of good information here, but right now this is what I want you to focus on, and I'd highlight or underline a few different points that I really needed them to focus on in the first little while, and I'd say to them, then if you feel comfortable or you feel like you want to read more, go ahead, but these are the main things I want you to focus on. So most importantly, we also need to check for understanding. So it's one thing to communicate, whether verbally or print, but the other piece of it is do people actually understand what we shared with them? So to the point at the beginning is, they've heard us, but do they actually understand? And so this quote's actually from the U.S. Surgeon General a few years back, and I can read it out loud, you can see it, but as clinicians, what we say doesn't matter unless our patients are able to understand the information we give them well enough to use it to make good healthcare decisions. Otherwise, we didn't reach them, and that's the same as if we didn't treat them. So basically, if we're sharing information with them that they can't do anything with, basically we haven't done our job, and they're just throwing it in the garbage or neglecting to follow through, and really we wasted our time and the person's time. So this cartoon just speaks to that. Take with meals, no problem. I eat all the time. So we need to check in with people. When we say take with meals, what does that mean? As an example, some people eat 3 times a day. Some people eat 1 time a day. Some people eat every other day. Who knows? And so we need to check with them. When are they taking their medication? What does this mean for them? So it's important to use teachback, and I believe that Lindsay mentioned to me that with the reminder that for this webinar that went out this morning, there would have been an attachment to our teachback cards. So teachback is not something we developed as a program. It is a universal technique that's been out there and it's been researched well. But you know, the reports show that only 20% of healthcare providers actually use it. We as a program developed those teachback cards that you would have received just as a reminder. So one is for healthcare providers, one is actually one we use in patient workshops to remind them that, you know, if the healthcare provider isn't starting this process, we want to empower you to as well. So teachback is not a test of the patient, it's a test of how well we did our job in explaining things. So basically, this next slide, the quick, easy steps is, you know, think about information ahead of time, try and chunk it into chunks. Use plain language when you're speaking with people and slowly, not quickly like I'm doing right now. Ask patients to explain it back, but you need to take responsibility for it. So what I mean by that is instead of sharing information with the patient, or maybe you're showing them how to do an exercise or something, you don't say to them, okay, now tell me back what you understood, or now show me. You need to start it a little bit different way. It's about starting it with, and whatever feels natural for you, but it could be something like, you know, I want to be sure I was clear. You know, I might have spoken really quickly, or maybe I didn't do a good job of explaining things. Can you tell me in your own words what you understood? Or can you show me how you're going to do that exercise once you're home or once I leave? It's just a way to check in, because if they missed anything, that's your opportunity to, you know, clarify. Maybe you have to say it a different way. Maybe you have to show them the exercise in a different way. And that way, with you starting the sentence by putting the responsibility on yourself, it's like if they did get something wrong or missed a step, they don't feel like they've done something wrong. You know, oh, well, I missed that step. Well, Sally said if she didn't explain things well, you know, that was her issue. So just keep that in mind. So the teachback cards that you were provided give you a good overview and I think would help you, definitely. These are just some sample starters, so maybe it could be, could you tell me back what we just talked about to see if I was clear? Or maybe after you leave this appointment and go home, you know, what might you tell people, you know, what happened or, you know, what you're going to do, just so you get a semblance of what they think actually went on in the appointment. And that way you can check in. If they've missed something, you're going to need to re-say it or re-show them, and then teach back again. Ask them to show them back or tell you back. If they got it, move on to the next step or move on to the next piece of information. But it's about checking in with people, not giving them 10 steps of things to do and then getting to the end and saying, do you understand? It's about maybe going through 1 or 2 steps, stopping, checking in, moving forward if they're ready to do that. Teachback can also be the show me skills. So maybe it's something you're showing them to do at home or, you know, wherever they may be. You know, can you show me how you're going to do this at home? Maybe it's showing them how they can, you know, use their puffer, you know, on their own, or it's an exercise, or it's testing their blood sugar. So you actually get them to show you back. So we need to stop, you know, to assess for understanding. What we normally do, many of us do, and I'll be guilty of it, is that we say, well, you know, we get to the end of something and we say, do you understand? And, you know, most people will shake their head yes, and some do understand, and others don't, but they'll still shake their head yes, and they'll walk out of the office or you'll leave their home, and they're thinking to themselves, well, I understood part of it, or maybe I didn't understand anything at all, but they're too ashamed to say that they don't. So what we need to do is make sure that we invite questions at the end. You know, not do you have any questions, because that's a yes and no answer. And again, people will say yes, no, they don't understand, or sorry, no, that they don't have any questions, and really they do. So you need to make it more open. What questions do you have for me? What parts of this were hard to understand? You can normalize it. You know, a lot of people, when I go through this information with them, they have a lot of questions or they struggle with things. What parts of this were difficult for you, or what are you struggling with? So just keep that in mind. It's just a different way of relating to people. So in summary, just to keep in mind that any one of us can have difficulty understanding health information. Put us in a stressful situation. Think about our patients, you know, who maybe lack of sleep, pain, maybe there's concerns about finances and they're stressed about that, whatever it may be. All those things can change the context of how well we can learn information. So low health literacy can affect people's health, their safety, their care and experience. So keep in mind that we need to create a shame-free environment, that we treat everyone equally and anticipate barriers, that, you know, sometimes they could come into us today and they're doing really well, but the next time they came in, they're struggling with something. And so how can we best meet their needs at that time and share information in a way that is, as adult learners, that is applicable to them, that they can use in their everyday life, that's applicable in the now, and not something they have to go back and still do more research on. So I'll leave you with this quote, that the greatest problem with communication is the illusion that it occurs. As healthcare providers, sometimes we think because people don't have questions, that people, don't question us, that, everything's okay, and truly sometimes that isn't the case. So that's just our contact information, which will probably be shared in an email. And Lindsay, I will leave it to here, I guess, to the questions, if anyone has any questions. Thank you very much, everyone.
Perfect. Thank you so much, Sally. That was great information. And we did have a couple comments just thanking you for providing such practical information and great examples as well, so that we really know how to apply what you've taught us today. So if there are any questions, I will encourage people to put their questions into the chat box. We'll also give an opportunity if you, instead of typing it all out, would just like to unmute your phone and ask. We can do that as well. So there have been a couple questions in the chat box about the slide deck and the recording and things like that. So the slide deck as a PDF will be circulated after the webinar. It will be circulated at the same time as a reading list that has been prepared by Mary Beth, who is our information specialist for the community of practice, and a few other supplementary resources, and the recording of this webinar as well. So to get all of that organized, it might be a couple days to a week from now, but you will have all of it. So our first question is from Annie. How effective do you think the word literacy test is to test materials in production?
So is that a specific test?
The Kincaid Flesh test, where you can do on Microsoft Word, you can check the reading level, the grade level.
Yes. So I will say to you that that is one tool in the toolbox. I would not put all your eggs in that basket. What I mean by that is there's other tests as well, not just the Kincaid Flesh. I know Microsoft Word uses that. One thing that I tell people during our workshop is that health literacy and making things more understandable isn't just about the reading level. And yes, we talked about how different documents are at certain levels. It's also the design of the document. It's also how we speak to it. So there's a number of factors that go into that. So yes, I think it's a tool in the box, but I wouldn't put all my eggs in that basket, meaning that especially the Microsoft Word, all of us probably when we work in Microsoft Word, we know there's a little button you can click and it tells you the reading level. What Microsoft Word doesn't tell us is that in order to get an accurate level, you actually have to what we call clean up the text. So for instance, any type of Word program or any type of these test programs, what they base the reading level on is how many syllables in a word and how many words in a sentence. So for example, if you have a sentence that says, Dr. Smith wants you to come in on October 1st for an appointment, and you do a test on that. It actually picks up, because you have doctor and then period Smith, it picks up doctor as a sentence because it thinks it's a period, and it thinks, oh wow, that's an easy sentence. It's only one word and it's one syllable or two syllables. So what it doesn't tell you is that you should be cleaning up your text. So what I would encourage you to do if you're developing any materials before you click on that button is, even though you may not send it off to the patient this way, write it out. Write doctor, actually doctor, D-O-C-T-O-R, Smith wants you to come on October 21st, 2016, and write it in. You will see a difference in the reading levels. So one thing it doesn't do is tell you to clean up your text, which means you have to write out everything, even if there's acronyms, even if there's periods, after doctor or Mrs. or whatever. The other thing to be aware of is if you have bullet points in your document, you need, in order to get an accurate reading level, you need to get rid of the bullet points and actually make them sentences first in order to get an accurate reading. So it's just to keep in mind, they are great tools, don't get me wrong. What it is in healthcare, it's very difficult to get down to a reading level that you'll hear people say, well, it needs to be at a reading level of grade 6 or grade 8. It is very difficult in healthcare because some of the words that we want people to learn, for instance, diabetes, put diabetes into one of these programs and it'll shoot your reading score way up. So But it isn't that we don't want people to understand, right? We want people to know what diabetes is. So you write diabetes, but then you also write what it is. So just keep in mind, I think they're great tools, but as one tool. You need to look at other things like how your document's designed. Is it visually applicable? Does it meet the audience? And what I encourage people to do, the best thing to do before you start printing thousands of your pamphlets or whatever it is, instructions, is develop a draft, give it to your next 5 or 6 patients, get feedback from them, because in the end, they're the ones that are going to need to use it. And they will say to you, we've done this many times in our program, I don't understand that word, or I don't like the flow of that, or that bullet, in the middle of the page doesn't make sense, or the title doesn't make sense, or that sort of thing. So that would be my answer to that. Sorry, long-winded answer.
That's great. That's really good information about the reading level. There was a question from Rosalie that sort of relates to that. So she says that she's heard the average grade level that most Canadians can function with is grade 6, but she doesn't remember her source. And I think you mentioned grade 7 or grade 8. Do you have any comments about what level health practitioners should be sort of aiming for?
So again, going back to those reading levels is any of the training I've done and the learnings is, they say to actually, if you can get to a grade 8 level, you're doing very well in healthcare. But the other thing I would say to you is that let's say you develop a document, you put it through some kind of reading scale, and it tells you you're at a grade 12 level, and you make a few changes. Maybe you get patient feedback, you make a few changes, and now it's at a grade 9 level. I think you've done fabulous work. You may not have gotten to grade 8, but you've done major work that you've gotten it down. So I always hate to say that there's a certain reading level. What the slide that I mentioned was around sort of the stats in the States of where people are actually reading at, which most people are reading at a grade 7 or 8 level. And so that's where they kind of tell you to gear health information to. But I will tell you, it is very difficult to do.
All right. Now there's a great question here from Kathy. If you were sending out a letter to a client summarizing your recommendations for them, is there a maximum number of recommendations you would want to give them?
Yeah, so I guess they actually say no more than 8 bullets on any document. So 8 recommendations, I would say. But then I guess I would go back to say, how involved is each one? If the first 3 involve a lot of work on the patient's end, then maybe 3 is enough. Or you could give the 8, but in your explanation say, please start with the first 1 or 2 and let me know how you're doing, or then move on to the next few. Because sometimes when people get something in the mail and it gives them like 8 things they have to do, it can be very overwhelming. So the studies actually show no more than 8 bullets. But really, when you're sharing health information, you should only be doing 1 to 3 things at the most. But if it's something that you may never see that person again, I would say, and you feel the need to give them all the recommendations, is put the 8 down, but put the most important or maybe the most pertinent to them in there. It might not be important to you, but it might be in their life right now that the first 3 are the most important, and maybe explain that to them, that try and focus on these 3. And if you're doing well, then move on to the next ones.
That's great advice. So I will give an opportunity now if anyone is waiting to unmute their phone line. We'll give an opportunity to ask a question over the phone to Sally. So dial *7 if you are interested in asking a question. All right, if there's no questions on the phone, we do have one final question in the chat box from Ellen. Do you recommend doing SMOG checks? SMOG standing for Simple Measure of Gobbledygook.
Yeah. So this is just another literacy sort of reading level test, just like the Kincaid Flesh. Again, all of these tests are great. It just means you need to clean up your text. I wonder, Lindsay, if it's possible, I have a document that actually share in my workshops that actually goes through this. It's a 1-pager double-sided that maybe I could send as a PDF to you and you could circulate it to the group with the email, because it gives more information on that. But basically, again, it's a tool. There's many. There's smog, there's Kincaid flush, there's, I can't even remember off the top of my head, there's like 5 or 6 of them. And they all measure a little bit differently, but again, I would say to you that it's a tool. It is something to start with, but also the design of a document is very important, just as important as the reading level. So if I could do that, Lindsay, I could send that to you. That would be great.
100%. Yeah, we can definitely circulate that PDF with our other resources at the end. All right, so we are at 1:05 now, so we're going to wrap up our webinar today. I'd like to thank so much our speaker, Sally, today for providing this valuable evidence-based information to help us advance our knowledge and our practices in health literacy. Thank you also to all of our participants for attending today and engaging in a great discussion. There were some really thoughtful questions at the end there. I'm going to ask that you please do not close this window until you have been redirected to the Level 3 lobby screen. Once you see that screen, it's safe to close the window and a very brief evaluation survey will launch in your web browser. We'd appreciate it if you could take a few minutes to give us some feedback. A recording of this webinar will be posted on our YouTube channel as well as circulated to all participants in the coming week or so, along with those additional resources we mentioned earlier. Feel free to pass these along to any colleagues who you think would be interested. For more information about the Fall Prevention Community of Practice, please check out Loop, our online communication platform. The address is fallsloop.com. Again, that's fallsloop.com, and it's an online communication platform, kind of like the Facebook for fall prevention. All right, have a wonderful day, everyone, and we'll see you next time.